Today we're going to be talking about senior pets and the fact that they need dental care as well. So let's kind of talk about some of the, things that we have with senior pets. And this is one of my favorite expressions or sayings out there, is that age is not a disease. It's just a consequence of not dying. And this is by Dr. Brooke Nemec, who is a diplomate in the College of Veterinary Dentistry. And this is so true. I was speaking with Emma, our moderator, before the meeting, and this picture here is my 16-year-old Sheltie. It was unfortunately the day I had to make the decision to let her go. She was unable to walk anymore, but I've been known to have long livers in my life. I have a 32-year-old horse. I have two 16-plus-year-old kitties in the house, and we tend to have these older animals, and they do need to have dental care as well. Now, I'm very excited to announce that the 2023 AHA Senior Care Guidelines for Dogs and Cats has come out. This was just released, probably within the last week, maybe, and there's even information in there on dentistry, and a good friend of mine, Dr. Heidi Loprise, who's a diplomate in dentistry, contributed to this these guidelines. So these are some statistics, and you guys have probably heard this 100 times, but 80% of dogs and cats over 2 years of age have periodontal disease. Well, we're talking seniors here. And actually, this statistic is a little dated. It's from 2013. And if we look at more recent data, it's probably closer to 85 to 90% of pets over 2 years of age have periodontal disease. And in another meeting I was in this morning, there was a correlation between the age of the pet, the size of the pet, and as they age, obviously the periodontal disease just kind of continues to go up on this giant graph. So we know these older pets are going to have some type of disease in their mouth. Unfortunately, one survey showed that only about 14% of dogs receive dental care at a veterinary practice. I think this is getting better, or I want to say I hope this is getting better than it was. This was in 2013 and 14. But even if, say, we were a little bit better, we're still missing the boat. If 85% of our patients have this disease, we need to do an oral exam on every patient every time we see them. I don't care what they present to the hospital for. We really need to be looking at their oral cavity to make sure that we're finding these problems and looking at ways to treat these patients early on so that we don't have to have that severe disease as these patients get older. And we know that there's some roadblocks. We really probably didn't get a sufficient amount of training in vet school or vet tech school. I know back when I went to tech school, seems like a million years ago now, but we got about an hour of dentistry, and it's really something that technicians can own. Many vet schools are not giving as much education as they could. However, in 2020, the AVMA has required that all vet schools teach a semester of dentistry to all vet students. So I think that's a huge improvement. And we know that we're just not putting enough emphasis on how important that oral cavity can be to our patients. We also need to be able to recognize pain and infection. And this is one of the definitions of what plaque is. And I think this is something that there's a couple things in this definition that I think are important. It is that it's an infectious disease caused by the plaque and the resulting inflammatory response. So two of the things that I see in that definition that I think are so important for you to understand is that it's an infection. Okay, it's an infectious disease, and it's caused by plaque. It's not caused by the calculus or tartar on the teeth. It is caused by the plaque and the bacteria byproducts of the plaque. Now, one of the things I will always say is if I were to take all of the gingival tissue off of, say, a golden retriever, we would probably have about the size of the palm of my hand. And could you imagine a patient or a client not demanding treatment with an infection that size on their pet? They're going to want to have that treated. Now, we also know that dogs and cats are experts at hiding pain, and they're probably not going to let that client or that the pet owner know, or the owner may not recognize the signs of pain that their pet has. So plaque, as I said, this is kind of what I'm most worried about in the oral cavity. It's a soft gelatinous matrix made up of bacterial and bacterial byproducts. It has salivary glycoproteins, there's bacteria, lipids, extracellular debris, and extracellular polysaccharides. Now, those glycoproteins and polysaccharides are what makes that plaque adhere to the tooth. Now, plaque doesn't just grow on the crown of the tooth, it also grows up below the gum line. And as it goes up below the gum line, it starts to change the type of bacteria that are present. So what it starts is, even if I cleaned a pet's tooth this morning, and within about 20 minutes, a biofilm is laid down. And that is going to be the bacterial, saliva, or salivary glycoproteins and debris. It starts to form within about 20 minutes of a cleaning. And if it is not removed, every 48 to 72 hours, it's going to calcify into calculus, AKA tartar. Now, the tartar itself is kind of like coral in the ocean. It really doesn't cause too many problems, except it gives more surface area for more plaque to grow. So kind of keep that in mind. And it's also important to remember that antimicrobials are not going to be effective on treating that plaque by itself. We have to go in and we need to remove that plaque and biofilm. And that's what's going to be so important, because it prevents that inappropriate host response, which is chronic inflammation. And when we have chronic inflammation and the chronic bombardment of these bacteria, we actually can have systemic issues for the patient. So we look here, this biofilm is actually there to kind of protect that subgingival plaque. And what it does is it reduces the amount of oxygen that's present. Well, when we have decreased oxygen, we go from being an aerobic to a facultative bacteria, and then even to an anaerobic bacteria. And as that maturation continues, we start to see a development of gram-negative bacteria. And these gram-negative bacteria can be black pigmenting bacteria that actually produce a tremendous amount of byproducts that can affect the way the gingiva is and the tooth's oral health is. It can produce something called thiols, and thiols are what is kind of that gives that bad breath, but thiols themselves are also destructive to the tissues. So as I said, those anaerobic gram-negative bacteria and spirochetes are there, and they start producing these endotoxins and those thiols and proteolytic enzymes. And all of these things are going to impair the neutrophils that are coming to try to save the day. And these neutrophils become activated, become toxic neutrophils. And they result in this inflammatory cytokines. And all of that together starts to form the destruction we see when we have periodontal disease present. And this is, a severe case of periodontal disease. We have all the things present here. We have, the first area that's going to be affected is going to be the epithelial tissues. And then as those bacteria continue to grow up subgingivally, it increases the sulcus depth. And then it starts to affect the periodontal ligament, as well as having the alveolar bone destroyed. So in this patient, we not only have gingival recession on that canine, we have furcation exposure on the second premolar, we have root exposure, we have red, swollen, painful gums. This is a very painful oral cavity. Now, there's consequences if we let periodontal disease go, and we have local consequences as well as systemic. And local are going to be things like oral nasal fistulas, where we have so much infection, especially in the palatal aspect of maxillary canines, that it actually communicates directly into the sinuses. We can have pathological fractures, where a dog could have so much bone loss in their mandible that they jump off the couch and they accidentally bump their chin on the floor and end up with a fractured jaw. We could have periocular damage. We can also have bone infection or osteomyelitis, and of course, tooth loss. Now, if you look at this oral cavity, this is actually a greyhound that I treated years and years ago. This dog had the most horrible mouth, probably one of the worst mouths I've ever seen. And every time that patient is eating, there's bacteria getting into his bloodstream. And that starts to affect their kidney, heart, and liver. Now, we know in humans there's some systemic links with periodontal disease. We can have a link to inflammatory bowel disease. We have a link with cardiovascular disease. They're finding some of these periodontal pathogens in the plaques in our arteries, and even in the atherosclerosis risk for communities, we can see things such as calcifications related to the periodontal disease, calcifications in the arteries, renal problems, stroke, and even thickening of the carotid artery wall. So we have all these things that have been documented in humans. And it's a little harder. We don't have as much veterinary data, but we have some, and we can pretty much extrapolate that what's happening in us is happening into these animals. So really one of the first studies that looked at this was in 1996. Dr. Linda DeBose did a study that associated the periodontal disease with histological lesions in multiple organs in beagle dogs. In 2005, we had a study on systemic effects of chronically infected wounds in the oral cavity of dogs, as well as in 2006, echocardiographic alterations in periodontal disease in dogs. And then in 2005, again, a mitral valve endocarditis after a dental cleaning in a dog. Studies are being done too that are tracking the systemic parameters with pre and post treatment for periodontal disease. So this is not surprising to me at all, is that when we have increased severity of periodontal disease, we have increased concentrations of these systemic markers, okay? And the systemic inflammation can be reduced with appropriate periodontal therapy. So just to kind of go through this really quickly, what does periodontal disease look like and how does it progress? Well, stage 1 is just gingivitis, okay? The gums might be a little bit red and swollen. They might bleed upon probing, but I have no evidence of bone loss. I don't have any pocketing. I don't have any recession of the gums, okay? When I get into stage 2, these gums are still red and inflamed, but we're starting to see about 25% bone loss. And we're going to start seeing furcation exposures of about a stage 1. When we get into stage 3, we're up to 50% bone loss, and we're going to start seeing what we call a furcation 2, where it's not all the way through, but we can get our probe fairly well into that furcation area. And then stage 4, these have over 50% bone loss. Most time these teeth are mobile. They probably need to be extracted. But what's so important to remember on this chart is that stage 1 is reversible. I can take a stage 1 back to stage 0 with a good dental cleaning and good home care. But once we start getting into stage 2, 3, and 4, it's not reversible anymore. Now, I don't have to let it go to the next stage. I can stop at stage 2 with good home care and dental cleanings, but I can't get it back. I can't get that bone back. So it's important to remember stage 1 is reversible. The rest of them can be halted, but cannot be reversed. So what is the goal when we're looking at treating periodontal disease, and even in our older pets, is that as prominent as periodontal disease is, it's preventable. Okay, we brush our teeth every day, twice a day, hopefully, and we're going to the dentist every 6 months or so to get our teeth cleaned. We are trying to prevent periodontal disease in us as humans. We can do the same in our pets. We can maintain oral health before those tissues are destroyed. And that's by regularly removing plaque and tartar, plaque and calculus. If we need to, we're going in and doing professional cleaning. We're going down below the gum line, cleaning all that bacteria out, and we're going to minimize pocket depths. Now, again, dental care guidelines of 2019 were out. I really recommend you guys going to these AHA guidelines and reading through them and seeing what you can do within your practice to ensure that we're taking care of senior pets, that we're doing good care of our pets, our dogs and cats. Now, antibiotics. Back when I first started in this field, everybody got an antibiotic about 3 days prior to a dental cleaning. In the more recent years, it is really hard for me to find say a dentist, a veterinary dentist, who can remember the last time they've even prescribed antibiotics. Because if we're doing a good job in our veterinary hospitals, we really don't need to do a pre-antibiotic or even a post-antibiotic after a dental cleaning. Now, if you're going to do antibiotics, this is going to be the veterinarian's choice, and we need to use them responsibly. We do have a huge problem with antibiotic overuse in our country. Now, the reason we don't do it like we did back in the day is because we figured out that bacteremia that we were trying to prevent with the dental cleaning is extremely short-lived, maybe about 20 minutes. So for the most part, our healthier younger pets can clear this without any issue. Now, if we have a senior pet who maybe has an immune problem or severe periodontal disease that I jokingly will say is grade 17 out of 4, those really bad mouths that you can smell coming in from the parking lot, or one who is a senior pet who has some other issues going on. Maybe they have some comorbidities such as diabetes or heart disease. Maybe then we put those patients on an antibiotic. Okay, but they don't, for the majority of our pets that probably don't need it. Now, one of my dogs, you'll see her at the end of this presentation, she had autoimmune mediated polyarthritis. So her dental procedures, she would get an antibiotic ahead of time just to make sure she didn't have any problems. Now, this poor girl, I'll tell you about her later too, but she passed away at 11, having seizures and complications due to her immune issue. But man, her teeth were perfect. She was grade 0, perfect teeth at 11 years of age. So it doesn't mean just because a pet's older, it doesn't mean they have to have bad teeth. So when we look at performing procedures on our older patients, I think one of the things that probably hurts my heart the most is when I hear clients or even people in my own profession in veterinary medicine who will say, well, my dog kind of needs to have a dental treatment done, but they're too old. And I'm always like, age isn't a disease, guys. All right. We really do need to make sure we're helping that patient, because all that bacteria, all that stuff in their mouth is affecting their overall body, and it doesn't make them feel good. Okay. So when we look at treating these older patients, we have to have the 3 Bs. We have to have bravery, we have to buddies, and we have to have blocks. Now, bravery means that we're not going to let that animal suffer because we're afraid to do a dental procedure on an older animal. If you are not comfortable in your practice performing a dental procedure on a senior pet, please refer them. The dental diplomates do these procedures on older pets all the time, and many of them actually work with a boarded anesthesiologist. So they have someone who is there to kind of help with those senior pets or pets who have comorbidities. Also, I cannot stress this enough. You need to have a buddy. And that means a dedicated anesthetist present, constant monitoring of the patient. I remember back 30 years ago when I started in this field, dental procedures were kind of done in the back of the back of the hospital. Nobody wanted to hear the scaler. You're back there by yourself, and you kind of knew something was wrong when the tongue turned blue, right? We didn't have monitors that much. We didn't have somebody taking regular vitals on our patients. We need to have not only a monitor hooked up for that patient, but we need to have someone who can actually lay hands on that patient, who can listen to their heartbeat, who can make sure that they're doing well. I'm a big believer. I don't trust my monitors 100%. They're a little bit behind what's actually happening in the patient, and they may miss something. And then blocks. And we're not going to really talk about placing dental nerve blocks here, but if you don't know how to place dental nerve blocks, they're super easy to learn. They're easy to do, and they add such a huge benefit because it keeps our patients pain-free. And the really important thing is we can keep that anesthetic low. Okay. My first time I placed blocks, they were for canine extractions on a fairly young animal. I was able to maintain those patients at less than 1% isoflurane for canine extractions. Okay. Because I had blocked that mouth and they didn't feel what I was doing to them. Again, just some anesthesia and guidelines, monitoring guidelines for dogs and cats, and pain management. Just because I preach this stuff all the time, but I want you to know that I'm not just making it up. It's coming from reliable sources. So what are the risks when we look at older patients? Well, again, I've already kind of alluded to this, but we sometimes have those comorbidities. Maybe they have a heart murmur. Maybe they have diabetes. Maybe they have something else going on with them. They might have decreased organ function. And sometimes in some of our patients, we might need to stabilize them before we can take them to anesthesia. So I used to have this discussion with my veterinarians all the time, is that we would always do what I call surgical safety blood work or pre-anesthetic blood work on every patient, not just our seniors. And we'd sometimes have a dog who came in with a high renal values. And my doctors are like, oh, we can't go to surgery. And I'm like, but if we can keep that patient on good fluids during the procedure, and we get rid of that constant barrage of that infection in their oral cavity, we can reverse those renal values. And we did it we did it quite often, where we actually took an elevated renal value and took it back to normal by cleaning up that mouth. So by treating the periodontal disease, we can improve these comorbidities. Renal function, maybe we're going to improve diabetes. Diabetes in many of our patients is caused by high cortisols, okay, high stress hormones. And when we have that constant barrage of that infection in their mouth, it raises their cortisol values. If we can get rid of that, we sometimes can reverse diabetes. We really have to make sure we're putting a lot of emphasis on our patient safety, though. We also should use a polypharmacy. And this means that we have from that pet owner, we get a complete list of all the medications and all the supplements that patient is on. Occasionally, there's some things we're going to want to discontinue, and I'm not going to go into all of those at this point, but you kind of know what we shouldn't have a patient on when we're doing a dental procedure, if we're worried about bleeding or something like that. We need to determine which meds can be given the morning of the procedure. So you always have those guys who are possibly let's say they're, need to be on a medication and has to be given with food. How do you go about doing that? Well, do you give them a little tiny piece of food with their diet so that they can get their medications on board? Be aware of any drug interactions that can happen. And if the patient is diabetic, make sure that we're giving them insulin and feeding them. That means, we want to kind of make sure we're looking at how do we do that preoperative fasting and postoperative feeding. We want to make sure that we're really keeping those diabetic patients as safe as possible. And that means sometimes doing sequential blood glucose measurements during the anesthetic procedure. We need to minimize our risks, though. And that, like I said, the surgical safety blood work or pre-anesthetic blood work, I just like surgical safety. It's kind of warm and fuzzy. Do that CBC, do a chem, do a thyroid panel on these older patients. Definitely do a UA, okay? I think urinalysis is one of the most underutilized tests we can do in our patients. And I think, we want to make sure their kidney function, especially in our cats, is doing well. In our older patients, we may need to run an ECG on them. Make sure everything is good to go before we take them to a dental procedure. Chest rads. Obviously, all my patients are going under anesthesia are going to have a full physical examination, and we customize the anesthetic protocols. That means we aren't giving everybody Ket-Val, okay? We're going to customize what is the safest anesthetic for that patient, and then the dedicated anesthetist and that constant monitoring. We want to use balanced anesthesia. That means we want to use multiple different drugs, because when we do that, we can minimize the drug effects, but we can maximize their benefits. Okay, now this sometimes needs to be tailored to a specific animal. Not everybody gets, it's not a cookie cutter where everybody gets exact same drugs. And it's going to depend on speed or breed. It's going to depend on blood work. It's going to depend on a lot of different things. And one of the most important things we can do is making sure that we're using pre-medication and sedation drugs to help keep that patient anxiety low. Because when we have an anxious patient, it's going to take more drugs to get them asleep. We want to talk a little bit about wind-up. We want to avoid wind-up, right? And that means we're going to give them the right drugs in advance so that the patient doesn't have that wind-up. Because when we have wind-up, it takes more of the drug to be effective. So we know and we can assume that a dental procedure is going to be painful. Okay. I mean, we all probably know that from our own lives. How many of us love to go to the dentist because, oh, we had a bad experience at some point in our lives, or we've heard really horrible things about a dental procedure, and we can just assume it's going to be painful. So we need to make sure we realize that, and we're doing preemptive analgesia. That means it's given prior to the procedure. And there's just some options here for you. Midazolam, diazepam, acepromazine, dexamethasone. These are going to have a more profound effect if they're used along with an opioid. Now, opioids, they're still a fairly common pain medication. I know there's a little bit more of a push in the anesthetic world to kind of go away from opioids in animals. I'm not going to get into that because that's kind of beyond my purview right now. But we need to make sure we're giving the patient the best option for pain. And that's going to be the veterinarian's choice. And we have to know the side effects, and we have to constantly monitor these patients. Now, there are poor choices for severe pain, and dental procedures can have severe pain, especially when we're doing a surgical extraction where we've cut tissue and we've removed bone. That's an orthopedic surgery. They're painful. Okay. Butorphanol, not very strong. Okay. And it can block other opioid effects. I always kind of tell people, I said, using an opioid like Torb is kind of like throwing an aspirin at a fractured femur. It's not going to do a lot. Now, buprenorphine's been out there for many years. It really can block other opioids, not as strong as we once thought it was. However, it can be added to regional nerve blocks to make them last longer. And it's a very small dose. It's only like 0.003 mg per kg, can be added to bupivacaine to make it a longer lasting block. And it can go up to 48 hours. Dental blocks, they're easy to place. Okay. And I do a ton of training on how to do blocks. They're very, very effective. They're inexpensive. And as I said, they can reduce the inhalation requirement. Like I said, my first time placing a block, canine extractions, kept that patient at under 1% isoflurane. And you don't need special equipment. You see what I have there? It has the syringe, several needles. I like a nice sharp needle each and every time, but I use 0.5% bupivacaine if you can get it. Okay. There are other options, and you can always reach out to me if you have questions about other options out there. I always joke that I'm going to write a memoir about being in veterinary medicine, and it's going to be entitled Backordered. Keep your patient hydrated. Sometimes these dental procedures are longer procedures. Okay. We want to make sure there's an IV catheter and that we have warm fluids going into the patient. It's great if you can go ahead and have a line warmer on there, but even if you can't, maybe take the line right before it goes into the leg and have it, kind of underneath the patient or something, so that the fluids going to the pet are warm. If we have a line warmer and it's got 12 inches before it hits the patient, it's going to be cool before it gets in there. We also can preload them when indicated. Preload them with fluids when necessary. Make sure that we're monitoring their kidney output, and watching for signs of overhydration is just as dangerous as dehydration. One of the big things that I think I see so often in practices not being done is maintaining body temperature on our dental patients. These patients, many of the times, these older patients, sometimes they're smaller animals and they're going to lose their heat very quickly. But even a big dog is going to lose their heat. So what happens is when we're cleaning the mouth, we're running a lot of very cold water into their mouth. Well, dogs and cats lose body heat by panting. Okay, so they're going to be colder because we're putting all that cold water in their mouth. I like to keep my patient not only warm, but dry. All right. I don't care if you use a hot dog. I don't care if you use a bear hugger. I don't like using just heating pads and things like that because of burns, but keep the patient warm, whether it's just rotating warm towels out of the dryer, but keep that patient covered up. The only thing I would change on this image is on that picture of the dog. I like to use the hot dog. I burrito them in, I kind of clip them in. And once I started using a hot dog, I never had below 98 degrees waking up. 99, I think, was about average for my patients to wake up even after a 3-hour procedure. Because when our patients are too low temperature, we can have mentation issues, cardiac function, healing is altered, and recovery is altered. But the one thing I would change on that image is I would not have my patient's head on a towel during a dental procedure. I might have that towel back up kind of behind their mouth, but I don't want that towel to get wet and then it wicks up onto the patient and makes my patient wet. So I try to keep that so that the mouth is over the grate of the table and I don't need to worry so much about the whole head and body and every part of my animal being wet. Again, monitoring. Make sure that we have a good monitor, not just a human. Human sometimes is best, but sometimes they can't tell blood pressure, right? So having a good monitoring system on board is huge. We want to watch for hypotension. Having that blood pressure between 100 and 160 is going to be optimal for perfusion. Look at your O2 saturation. We want to see them at 95% or higher. If they get below 90%, we start having hypoxemia. If it goes down below 72%, stop, okay? And we need to have rescue actions on board at that point. And if you have, really recommend getting end-tidal CO2. It's so important that we not only are monitoring what's going in, but what's coming out of that patient. Now remember, dental procedures on our older patients with severe disease are going to be longer procedures. We may need to stage them. And that's becoming very common practice is that, we can look at a patient, we can do the cleaning, and we can say, okay, this dog or this cat is going to need, just say, full mouth extractions. And if your veterinarians are not, extremely experienced in full mouth extractions, it might take more than 3 hours. So maybe we do one half of the mouth and then bring them back in a month to do the other half. Okay. You have to make sure if you're going to do that type of staging that your client is willing to do it and they're going to come back. Okay. Like I said, some people will do the cohat, get that infection under control, and then do the additional therapies at another time. 3 hours is a long time. Okay, that's kind of the rule of thumb is 3-hour procedures, the longest I'm going to go. So kind of keep that in mind and make sure, like I said, you set those expectations up for the pet owner, that they understand that there may need to be additional procedures. Now, just because my patient is now had the dental procedure, now they're in recovery, okay? I don't stop worrying about them once they're in recovery. I want to make sure that we're monitoring their pain, we're maintaining their fluids until they're discharged, and we're monitoring them closely. The majority of pet deaths from anesthesia happen during recovery. So we need to make sure we're constantly watching them. And yeah, we place nerve blocks. We've got blocks on board, but that block is going to wear off. What are we going to send home with that patient for pain management? How do we keep them under control? Maintain, like I said, keep those fluids on them until they're discharged and monitor them for urine output, hypothermia, bradycardia, all through that recovery period. Now, there are things we can do for our patients. Yes, we can send them home on NSAIDs. We can send them home on pain management, but there are other options available. And one of them is the dental loop. Now, this is the loop that can be, and it uses targeted pulse electromagnetic therapy. It reduces oral and dental pain and inflammation. It reduces the swelling that can happen after dental procedures or any type of orofacial trauma or surgery. Again, it can also reduce the need for opioids and pain medications. I don't think it's going to 100% replace those, but it can help reduce that. And these are really simple little loops that you can, the owner can hold over put the dog's muzzle in that loop, for 2 to 3 times a day for 10 minutes, okay, or 15 minutes, and it will help with that inflammation. They also have, and I don't have a picture of it, I apologize, but they have like a cat. You got a cat. Cats don't really like to sit there and have something held over their face, but they have, it's basically a cat carrier that has a pad on the inside of it that has the targeted pulse electromagnetic fields going on there. So it's kind of like a little house for the cat to go into. So these are things that can help our patients feel better faster. This is another option. You can do it with an e-collar if you like. My dog would probably prefer me just to hold that over her muzzle rather than to have an e-collar on. Now, once a patient is discharged, we want to obviously send something like that home with them, but we need to take time to talk to our pet owners. We can't just hand them the invoice and say, well, we cleaned up everything, they're good to go, see you later. We need to go through things with them. We should go through the charts. We should look at radiographs with them. We need to go into detailed care instructions. This is, in my opinion, as a veterinary technician's job, all right? So especially the veterinary technician who did the procedure, okay? They should go over what we found. They can talk about what's on the radiographs. They're going to talk about immediate care, and they can talk about long care, home care for the dental home care afterwards. They need to go over how to give the medications, when to start, how to do it, and then also set up that follow-up appointment. And depending on the patient, 1 to 2 weeks post-op, we did a follow-up appointment on every dental patient, even if they didn't have a surgery done or lost a tooth. I wanted to have them come back, and they met with me again. It's a tech appointment. And we went over how things were going. So if it was a surgical procedure, we could see how the incision was healing. If no extractions were done or anything like that, then I would still come and meet with them so that they could talk about, well, we talked about this home care. How's it going? If the home care is going great, wonderful. If not, we can come up with other options for that patient for home care. So it's a great time to not only blend that or help that client bond with your practice, but it's a great opportunity for client education. One of the things that's so important to remember with discharge is on your feline patients, and this happens a lot. The cat goes home, you call them a day later, 2 days later, see how things are going, and they're like, well, I really don't know. I haven't seen him since I came home. The cat's in hiding. Well, you need to make sure that pet owners understand that's not good, and they need to see that pet every day to make sure that everything is going well for that pet. So kind of keep that in mind, that we have, that they're keeping a good eye on their patient post-surgery. So we've kind of talked about the senior pets, but let's talk about some of the common pathology we see in our pets at this point. So this is obviously why radiographs are so important. We have 3 different radiographs here. And doing a dental radiographs, and if you don't have dental radiographs in your practice, I hope that you invest in them soon and that you get proper training on how to take x-rays. It's not something that is just intuitive, okay? But, on the one on the very far left there, as you're looking at it, if I didn't have that x-ray and my doctor went in to remove those canines, we're going to have fractured jaws, okay? Same on the middle one. And, on the one on the right, I've got a couple teeth that are trying to make a break for it, okay? We have tremendous amount of bone loss on these patients. Another thing we see, and it's not always senior pets, any cat or dog can get gingivostomatitis. It can happen at any age. It is chronic. It's painful. These cats will come in. Now, most time owners will say, well, they're still eating and drinking. Well, quite frankly, a dog and a cat really don't stop eating and drinking unless it's really severe. Now, I can imagine this cat not wanting to eat. It's a pretty severe, painful mouth. We want to rule out things like feline leukemia and FIV. There is a link, or at least suspected link, between Caries virus and gingivostomatitis. We know that there are certain breeds of cats that are more prone to stomatitis. There's all kinds of wonderful potential treatments that could be done. Some of them aren't available here in the United States, but realistically, none of them are 100%, and most of them are not going to even be close to treating this. Unfortunately, the best treatment out there is going to be complete dental extractions, all teeth, Make sure you follow up with an x-ray afterwards to make sure you've removed all of the tooth root and dentin, because otherwise it may not heal. And even with full mouth extractions, we're only about 80% effective. There's kind of two schools of thought, and the majority of the dentists out there think that it's a reaction to plaque. Okay, they're allergic to their own plaque. Now, I can see that, but as a researcher myself, I also think there's a reaction to their own dentin. In cases that we did, we would have cats that came in and full mouth extractions, and we still had film back in the day. And we had a couple cats that just didn't heal in certain spots. And we would send them off to a specialist who had digital x-rays. And sure enough, we had a little tiny root fragment in there in those areas where they weren't healing. And that was enough to cause, once we got that root fragment out, the patient healed up fine. Okay. Those 20% that don't recover because of complete dental extractions, they may need to be on some type of a steroid the rest of their life. Is it going to probably shorten their life a little bit? Yes. But are they going to be more comfortable? Definitely. In a situation like this guy, I would probably think about having my doctor put him on a steroid for a few days or a week beforehand to kind of calm some of that tissue down, because there's going to be like trying to suture hamburger, right? Tooth resorption, again, can happen in patients of any age. We see it in both dogs and cats now. It's been 5 different names since my 30 years in the field, but tooth resorption is what we call it now. And there's stages, and it's based on the degree of involvement in the crown, as well as how the radiographic appearance of the periodontal ligament looks. So we do see more and more tooth resorption in dogs than we ever used to. And when we see it in dogs, we treat it like we do in a cat. So for instance, I'm going to go back a second. If on this x-ray I have here, this is a type 1 tooth resorption. The periodontal ligament is still present. I don't know if you guys can see my cursor, but I can kind of move it along here. I can see the periodontal ligament. And if I can see that, then I'm going to need to do an extraction, or my doctor needs to do an extraction. Now, if the ligament is gone and the tooth is kind of resorbed and all the looks pretty much uniform, there's no root present, they can do a crown amputation. That's a type 2. Type 3 means we have one of each root. You can go to the avdc.org website and get images of all of these different stages of tooth resorption. But in dogs, we're seeing more and more of it. We have some internal resorption in that white arrow, and then in the red arrow, we have some on the root. Well, with that root tooth resorption, in a dog, we can do a little bit of a wait and see. In a cat, I'd be having that tooth out of here. But in a dog, we know that it isn't painful until it hits the crown, okay? And it may never progress. In dogs, it doesn't always progress as fast as it does in a cat. So we can kind of wait and see. In humans, tooth resorption isn't painful till it hits the crown, and some people live with tooth resorption on their roots their entire lives. So just kind of be aware of that for recommended treatment. Alveolar bone expansion, which is what we used to call chronic alveolar osteitis, is when we have those cats that come in with those bulging maxillary canines, that bulging over their maxillary canines. That is due to chronic inflammation, chronic disease up below the gum line. And what happens is that bone starts to change, okay? And the bone, instead of being nice and tight, it looks a little bit like cottage cheese, or not cottage cheese, but like Swiss cheese. It's very lacy and it's very inflamed bone. And what happens when we have that inflamed bone, it pushes the tooth out. Okay, so we get extrusion along with this bone expansion. Those cute long canines that we see on some pets is not cute. Okay, that is due to chronic inflammation, chronic infection. We need to remove the teeth. We should biopsy the bone and then remove as much of that necrotic bone as absolutely possible, and then suture them shut. Now, the one on top is a cat that we had for many years in our practice. The owner would not let us treat that. Basically, when the owner went to Europe for the summer, she gave power of attorney for treatment for her cat to her mother. Her mother was also our client, and she came in. She goes, "Get rid of that tooth now." basically that was a pretty easy extraction, but a lot of work getting rid of all of that necrotic tissue underneath. Again, here's just that extrusion that happens with it where the tooth is kind of being pushed out. It can cause trauma to the lower lip. Okay, we need to make sure we're extracting that and removing all of the infected bone. I know that's a dog, but we have discolored teeth too, right? Where, you know, we have to make sure whether that tooth is discolored because of intrinsic or extrinsic stain. Intrinsics internal, extrinsics outside. Most of the time this is due to pulpitis. Somehow along the way, this tooth was damaged. And what happens is in the pulp chamber are the blood vessels, right? Well, between the pulp chamber and the enamel is this stuff called dentin. And dentin is made up of 52,000 microtubules per square millimeter. So when that pulp is damaged and it bleeds, all that blood gets into those microtubules. Okay, well, that's what causes that kind of purple look. Well, when blood gets old, it turns brown or gray. And that's why we have those discolored teeth. We used to say, you know, we can x-ray them, we should be looking for them. We used to say, well, kind of watch them and see if they're reversible. The recommendation now is just either extract them or have them off for a root canal or endodontics, because chances are we don't know for sure if they're painful. The dog can't really tell us. And a lot of times they're going to create an lucency abscess afterwards. So let's treat it before we get to that point. When it comes to fractures, we have a lot of different types of fractures. This is an enamel infraction. It is where that looks like a lot of cracks in that enamel, but if I take an Explorer and kind of rub it up and down, I'm not feeling any of them, and it doesn't really affect the structure of my crown. We just want to document that there's some enamel infractions in this patient. Now, when we look at other fractures, when we look at an uncomplicated fracture, that is where the pulp is not exposed. So the one on top is an uncomplicated crown root fracture, and the one on the bottom is an uncomplicated crown fracture. And there's complicated, excuse me, I should have fixed this slide, I apologize. Uncomplicated means there's no pulp exposure. Okay, so the top one is a crown root fracture. The bottom one is an uncomplicated crown fracture. When we have a complicated, then we have the pulp is exposed. Okay, top one is a complicated crown fracture of a canine. That brown stuff you see in there, that black, is actually called tertiary dentin. And what it does is the body tries to heal itself. So when that pulp is exposed, the body lays down this tertiary dentin to kind of seal that pulp, but it also traps bacteria in there. So that's why we can sometimes have a abscess form after a crown has been fractured. Now, the bottom one is a complicated crown root fracture. There's nothing we can really do to save that tooth. The top tooth could be saved with the root canal. The bottom one, or the bottom picture there of that 08, is not going to be saved. We also get root fractures, and sometimes this happens where you're doing an oral exam and you're looking around and you really don't see anything. You think you got a loose incisor, and you take an x-ray and it's really not a loose incisor, it's a fractured root. So we can also have root fractures. We will see caries in some animals. Cats do not get cavities or caries like people do, but they can get them, and they're going to be back on these back molar teeth, and they're going to be kind of a pit. And these can be treated just like we would treat ours with a filling, but they're actually truly tooth decay. Periodontal disease is not tooth decay, it's an infection that destroys the tissue around the tooth. I haven't seen very many caries in all my years. You don't see them very frequently, but they do occur. We also look at abrasion. Abrasion is external wear from an external object. This is a dog who'd chewed on tennis balls his whole life. You can kind of see, you can put that tennis ball in his mouth and see that roundness in there. You'll also see this from cage chewers or animals who constantly chew their skin. Will have, like an allergy dog, will have worn off incisors. Attrition is tooth on tooth, where because of a bad bite or malocclusion, the teeth are rubbing together and are leading to abnormal wear on the tooth. We also will be more prone to see oral and gingival masses. These can be, we need to look at the entire mouth when we're doing an oral exam and dental cleaning. We want to look at the palate, the cheek, the tongue. Always look underneath the tongue. A lot of bad things like to lurk there. Anytime you have a mass, even if you think it's just a little blip epuli on the tooth, biopsy it, okay? This happens to be a melanoma. This is a bad guy, okay? But I have seen little tiny growths, what we would refer to as an epulis, actually be acanthomosis amelia-blastoma. Okay, so it can be a cancerous thing. We should always biopsy and then make sure we know what we're looking at. There's the word, acanthomosis amelia-blastoma. All right, that one on the top, pretty good sized one. We get gingival enlargement. That can happen with certain breeds where it used to be hyperplasia. Now we call it enlargement. But anytime we have a mass, we need to biopsy it. Oral tumors in cats, the most common out there is squamous cell carcinomas, and it's in our older cats. Our 11 to 13-year-old seems to be the median age. You're going to have facial swelling, salivation, maybe not wanting to eat, anorexia, and weight loss, malodor. They like to lurk underneath the tongue as well. And then the second most common we see in cats is called fibrosarcoma. It's not very common. Okay, it's second most common we see, but it occurs very rarely. And again, it's on 13-year-old plus cats, usually in the rostral aspect of their mouth. Again, it presents almost identical to squamous cell carcinoma. We can also get contact mucositosis ulceration, which we used to call cups. That's just because the tissue, the disease and the inflammation and the plaque on the tooth can actually affect the tissue that comes in contact with it most frequently. So like, for instance, up here in this tooth back here, we have a tooth that's pretty covered with plaque. The cheek tissue that is constantly covering it is getting inflamed as well. And then in this picture on the right, we have osteomyelitis, bone infection. We can also get draining tracts. That dog is from an abscess fourth premolar. A cat abscess usually doesn't blow out into a fistula like on the dog, but they will get draining tracts similar to the cat there. Oral nasal fistulas, we've kind of already discussed those a little bit, but that's direct communication, usually going to be on the palatal aspect of a canine, most common in dachshunds, but I have seen them in almost every breed. Remembering to do an annual cohat. Start early. I actually do not like the term dentals. It drives me crazy because dental is an adjective. Okay, it doesn't tell our pet owners what we do. We have a dental instrument. We have a dental x-ray machine. A cohat is a comprehensive oral health assessment and treatment. It really tells the pet owner what we're doing. We need to start these early, and we need to start them at stage 0 or stage 1 so we can prevent it. We don't need to have severe infections. We don't need to have tooth loss and other issues going on. We can have healthier pets. Remember at the beginning of this, I talked about my dog who had polyimmune-mediated arthritis. Well, this is Xena. This was her. She was about 10 and a half in this picture. She was a big girl, but her teeth were perfect, even though she had another health issue that affected her longevity. Again, the loop. Just to let you know, if you're interested in being a VTS in dentistry, you can go to the avdc.us website, or if you just like dentistry, think about joining the Foundation for Veterinary Dentistry. If you've liked what I've done today, you can go ahead and follow me on Beyond the Crown Veterinary Education on Facebook. Make sure you put veterinary education or you get a lot of beauty pageant stuff. Or you can go to my website at btcveted.com. I do have a textbook out. There's a link on my website to that under the resource tab. It's a great book for technicians, but also for veterinarians. Lots and lots of pictures of pathology and things in that textbook. And I just want to thank you. This is my 16-year-old cat, Ricky, also known as Ricochet, who just wanted to thank you for your attention today.